I am going to be starting the webinar.
Okay.
I'll let people join.
Hello, good afternoon. Am I audible?
Yes, you are, Dr. Kiran.
Okay. Just let me know when we can start.
You can begin anytime.
Okay. Okay, good afternoon, everyone, and welcome to the SingHealth ICU webinar. Today, the session is on tracheostomy care. My name is Kiran Sharma. I'm the head of intensive care medicine at Sengkang, and I'll be the moderator for today's session. As they say, it takes a kampong to raise a child. Perhaps that's very true for a trachea patient as well. This webinar brings along experts from ICU, nursing, physiotherapy, speech therapy, and respiratory therapy department to share their insights on safe and effective practices for trachea care and for trachea patient. Our SKH Trekkie team, we have Dr. Ganesh, who's from Respiratory and Critical Care Medicine. We have Ms. Goping from ICU Nursing. We have Ms. Grace from Speech Therapist. We have Ms. Trahada from Physiotherapy, and we have Ms. Luziel from from Respiratory Therapy Department. This session will be for 1 hour, and we will take questions at the end of the sessions. If you have any questions, you can always type in your Q&A, and we will try to answer as many questions as possible. So to start the webinar, I will give the floor to Dr. Ganesh.
Good afternoon, everyone. Thank you, Kiran, for your kind introduction. Okay, so this will be the contents covered today. It includes anatomy, indications, when to do tracheostomy creation, components, nursing management, swallowing and speech, weaning of tracheostomy, decannulation, and at the end, we will be having a tracheostomy emergencies as well. Okay. Let's begin. So we are all aware that more and more patients with multiple comorbidities and expected poor outcomes are being admitted to ICU and placed on mechanical ventilation. So in this day and age, tracheostomy has and will become a common practice. So it's time to upskill ourselves in managing these trachea patients. Globally, about 10% of ventilated patients are getting tracheostomized. I don't have the data for SingHealth, but in SKH over the last year, I can see about 5 to 6% of ventilated patients are getting tracheostomized. Today, we will discuss the fundamentals of tracheostomy, covering indications, timing, and the technical aspect of it. Okay, so a tracheostomy is basically a creation of a surgical airway directly in the cervical trachea. Creating a hole in the trachea is called as tracheotomy. The whole process of creating a hole and putting the trachea tube in is called tracheostomy. We need to differentiate a tracheostomy from laryngectomy, which is shown in the right extreme, where trachea is directly opening into the front of the neck. So you need to remember that no connection is there between nose and mouth and the trachea. A tracheostomy can be classified as temporary versus permanent, permanent being those for neurological patients. And also it can be classified as emergency, where we do it for those who failed intubation in theater, or can be elective, what we do in intensive care. A bit of basics. We all know that trachea is a D-shaped structure with a chondromembranous structure. With the posterior membrane is there is no cartilage. The anterior portion is covered by tracheal rings. It starts from C6 to T4. It's about 11 centimeter in length, with internal diameter varies between 18 to 25 millimeter. We all know that since it bypasses the upper airway, the natural warming, humidification, and filtering is lost. It may also alter the swallowing and vocalization, and it reduces the smell sensation. These are the three main indications. The first one is the most common, which is the anticipation of prolonged mechanical ventilation. A prolonged mechanical ventilation is more than 3 weeks of mechanical ventilation. The second one is bypassing the upper airway obstruction. It may be due to trauma or tumor. The third one is the airway protection, be it a stroke or the neuromuscular conditions, cervical cord injury patients. So to understand better, let us consider a patient Mr. G, who is a 70 years old male, who was admitted to ICU with pneumonia and ARDS. He's day 7 into intubation. So my team is asking, boss, can we consider a tracheostomy in this guy? So as an intensivist, I should be able to answer these 3 basic questions. Why should I do tracheostomy? And when should I be doing on him? And how am I going to do it? Okay, let's try and answer the first question. What benefits does trachea is going to offer compared to an endotracheal intubation? So historically, many benefits have been attributed to this procedure, but as we will see, the evidence doesn't always support our assumptions. So to begin with, let's see whether there is any mortality benefit. What you see in the left side is a French study done in 25 centers. They followed up the patient for 2 months. There is no mortality difference between a tracheostomy patient and those who are on a long-term ventilation, endotracheal intubation. The right side is a larger study done in Taiwan. It's about 1,400 patients. Again, you can see 2 lines kissing each other. There is no difference in mortality between a trachea and intubation. There was another study done in Italy, which followed up the trachea patients for a year, and they noticed the mortality at the end of 1 year is about 55%, which is basically 1 in 2 tracheostomy patients have died. They have a very poor quality of life and difficult rehabilitation. In this study, they noticed that patients with a high SOFA score on the day of trachea and also increasing age had a higher mortality when tracheostomized. Well, okay, so mortality is not the only consideration for daily decision making. So let's move on to other benefits. In terms of patient comfort, yes, this only trial which showed that 13 patients who underwent trachea were asked to compare trachea versus endotracheal intubation. All 13 preferred tracheostomy. I would have thought a broader patient-centered question may be, how many extra days of translaryngeal intubation would you accept before getting tracheostomized? Anyway, consider this one. Let's see whether there is any physiological advantage. From the physiological standpoint, contrary to common perception, airway resistance, lung compliance, and dead space volume of tracheostomy tubes are comparable to endotracheal tube. There is no clear advantage in this sector either. In terms of sedation, yes, tracheostomy patients may allow for less sedation and potentially faster weaning, but these benefits are not consistently demonstrated across all patient population. You can see in this trial, a UK-based trial, there's less sedation for those who are tracheostomized. The evidence of short ICU stay or hospital length of stay is also mixed. Like in this UK-based largest RCT, there is no difference in both groups. In terms of safety, tracheostomy was actually associated with increased post-ICU mortality when the tube was left in place compared to those who got decannulated prior to ICU step down. So you can see the lines splitting apart. This study makes us think if we should decannulate those eligible patients before stepping down. But our bed situation mostly won't allow this practice, I suppose. Okay, in terms of infections, evidence for fewer pneumonia with tracheostomy also questionable, with studies showing mixed results. When this study supports, but then this UK-based study didn't show any change in antibiotic use between both groups. Okay, so most of the proposed benefits got crossed off. So what benefit remains? So we can confidently attribute to tracheostomy is it improves oral hygiene, facilitates communication, it decreases patient sedation, it improves patient comfort, that's for sure. It also increases provider comfort with a secure airway. So let's say I'm convinced that my patient would benefit from a trachea. Now I decided to put him on a trachea, but my next hurdle is when to do the tracheostomy on him. Okay, one of the most challenging aspects of tracheostomy decision-making is when to do it. So the true medical wisdom lies in avoiding two scenarios: performing on patients who are close to extubation and on patients who are not likely to survive. Okay, so let's say what the evidence has. This is done in a subgroup of patients who have a traumatic brain injury. This is a systematic review of 9 studies, total of 5,000 patients. No difference in mortality, but there is shorter ICU length of stay and also a shorter mechanical ventilation day. So in patients with spinal cord injury, again, yes, early tracheostomy is a beneficial intervention for traumatic SCI patients. Even though there is no mortality benefit, there is, again, there are other advantages to it. But unfortunately, stroke patients, the meta-analysis didn't support for early tracheostomy. So they concluded that patients' timing was not associated with the mortality benefit, neurological outcomes, or either ICU hospital length of stay is not affected. So if we see an undifferentiated population, I mean those who are on prolonged mechanical ventilation, this UK-based multi-centered study, which involved 72 ICUs over 4 years, they did for 900 patients. They showed, again, there is no mortality benefit between early, which is 4 days, versus late, which is 10 days. Though there were fewer days of sedation in early group, it didn't translate into reduced ICU or hospital stay. A similar study done during the same time did for early as 8 days and 14 days also had the same outcome. In this Truckman study, you can see there's the red box there. Those who are assigned to do a late tracheostomy, only half of them, that means 45%, had a trachea placed at the end. So most of them either got extubated or passed on. So from this, I think for our patient, I think I decided to wait for 2 more weeks total, and I would prepare him for trachea insertion at that time. So the next question at the end of 2 weeks is, how am I going to do it? Okay, so there are 2 main approaches: surgical and percutaneous tracheostomy. Each has its own advantage and consideration. Okay, so percutaneous dilatational tracheostomy involves dissection of the anterior pretracheal tissue and the insertion of the tube under direct visualization using a modified Seldinger technique and bronchoscopic guidance. I'm not going to go through in detail, so I'll pass on. So next will be a surgical tracheostomy done by our ENT colleagues, general surgeons, involving a formal surgical approach with the dissection down to the trachea and creation of a controlled opening. Both techniques carry the risk, acute complication being bleeding, posterior tracheal wall injury, pneumothorax. The late complications can be a delayed bleeding, can be infection, a tracheal stenosis, or tracheoesophageal fistula. So looking at which one is best, the meta-analysis done, the recent one is 2014 one. They say there is no significant difference in mortality or tracheal stenosis or procedural bleeding in both the procedures. Both has some advantages, like percutaneous techniques perform faster and it reduces stomal inflammation and infection rates. However, surgical techniques are associated with fewer technical difficulties. So I decided to go for percutaneous at the end. So these are my takeaways at the end of my 10-minute session. Evidence is clear. Over 20 RCTs showed no mortality benefit from early tracheostomy. So I think timing matters less than appropriateness. The focus should shift from when to trachea to should we trach. We can use some prognostics tools to assess the patient, which can help us guide in decisions, like a Provence score or the SOFA score, which we discussed earlier. So for those who are mechanical ventilation patients, there is always a prediction error. So it's better to delay the decision for 10 to 14 days. Exceptions are patients who may require early tracheostomy would be those with neurological issues like traumatic brain injury, which we mentioned earlier. So at the end of the day, individualized decision for the patient we are caring is the best approach. In terms of the how are we going to do it, two approaches are equivalent in terms of both efficacy and safety. The ability to perform percutaneous at the bedside is a major advantage, but surgical techniques may be safer in those who have a high ventilatory support, uncorrectable coagulopathy, or unfavorable neck anatomy. So with this, I pass it to my colleague, Luisa, to carry on from here. Thank you.
Thank you, Dr. Ganesh. I'll be covering the components and the classifications of tracheostomy tube. So first off is the flange, or the faceplate. Is it part of the tracheostomy tube that extends to the outer part of the tube and has holes on each side to attach the tracheostomy ties. We can also gain important information on the flange, for example, or the brand name, the kind and the size of the tube. The outer cannula or tube shaft, this makes up the main component of the tracheostomy tube, and it is the part that is inserted and seated in the trachea. It can be a cuffed or a cuffless, a fenestrated or a non-fenestrated. The cuff offers some protection from aspiration and allows effective positive pressure ventilation. The pilot balloon is located at the end of the pilot line or the cuff inflation line. It is used to deflate and inflate the cuff of the tracheostomy tube by introducing or aspirating air using a syringe or a cuff manometer. It also shows indication of the cuff's inflation status. The inner cannula is placed inside the outer cannula that can be easily removed and replaced to allow for cleaning and therefore can prevent obstructions such as mucus plugs. There are a few mechanisms in pulling out the inner cannula. One is the pull-out mechanism, which we can see on the Portex brand, the twist and click on Shiley, and the clip mechanism on the Traco. The obturator is a rigid shape that goes into the outer cannula. It slightly extends beyond the tracheostomy tube, and the purpose is to assist with the insertion of the tracheostomy tube by maintaining the shape and avoiding damage to the trachea in view of the smooth, rounded edge. The plug here is placed on the tracheostomy tube to redirect airflow through the upper airway and vocal cords, allowing for speech and potentially facilitating swallowing. Plugging tracheostomy is a step towards decannulation, the process of removing the tracheostomy tube entirely. The last one is the subglottic suction port. It is a dedicated channel and a port above the cuff to allow for the removal of secretions collected at the subglottic space or above the cuff. It is designed to help in the prevention of ventilator-associated pneumonia and reduce the risk of microaspiration. It is also used to facilitate above the cuff vocalization for communication. Trach tube classifications. We have the cuff tubes. This is with a balloon at the end of the tube, providing proper tracheal seal, hence allowing more effective ventilation on patients on mechanical ventilation and preventing aspiration. It allows direct flow through the tracheostomy tube to the lungs and preventing air leaks. It is mandatory to monitor cuff pressure to avoid pressure-induced tracheal mucosal ischemia. Cuff pressure is maintained at 20 to 25 cm of water. We refer to the pilot balloon to determine if cuff is inflated or deflated. Fenestrated tubes. The key feature is the presence of one or more holes or openings of the tube. These fenestrations allow air to pass through the tube and up to the upper airway when the fenestration is not covered. It facilitates speech, improving coughing, and used as a step towards decannulation and allowing patient to gradually adjust to breathing through the upper airway. Non-fenestrated tube are the most common type used in tracheostomies. It lacks the opening that allow air to pass around the tube and into the upper airway. It is designed to provide a secured airway for patients requiring mechanical ventilation and used in patients with high risk of aspiration or swallowing difficulties. Also used in suctioning secretions from the trachea. The most common tracheostomy tubes we use in SKH are the Portex, which is recommended to change after 29 to 30 days. The Traco is recommended to change after 29 days for the cuffed and then 5 weeks for the cuffless. And then lastly is the Shileys, which is recommended to change in 3 months. Now I'll be handing the time over to Sister Gubing, who will be sharing more about the nursing management for trach patients.
Thank you, Lucille. Patients with tracheostomy bypass the upper airway, which naturally warms and humidifies inspired air. Adequate humidification is essential in tracheostomy care as it maintains optimal airway moisture, facilitates effective secretion clearance, and minimizes airway irritation and discomfort. There are two types of humidification, active and passive. The pictures here shows a passive humidification using the heat and moisture exchanger in a mechanical ventilated patient. Active humidification system in hospital settings consists of oxygen source connected to a heated nebulizer, ventilator circuit, and tracheostomy mask for delivery, water traps installed along the circuit to collect water condensation. Key points to take note here. Oxygen delivery is prescribed and monitored as a percentage rather than flow rate. So the correct oxygen percentage should be verified via the nebulizer adapter indicator. A regular emptying of the water trap is essential to prevent condensation accumulation in the circuit. Trache suctioning is a sterile technique. Pre-oxygenate the oxygen-dependent patient. The recommended suction pressure is between 80 to 120 mmHg. Sometimes may need to increase the pressure if the secretion is thick, but not more than 150 mmHg. When doing suctioning, introduce the suction catheter without applying suction. When felt resistance or patient coughs, withdraw 1 to 2 cm of the catheter and apply suction. The duration should be between 5 to 10 seconds. Observe patient during and after each suction attempt. Allow 2 to 3 minutes between suctions for reoxygenation. For patient using fenestrated tube, please remember to change to non-fenestrated inner cannula to prevent suction catheter from getting stuck or going upwards. Inner cannula need to be changed every shift to prevent blockage. During the change, use one hand to hold the flange, while the other hand removing the inner cannula by twisting or pulling out on a ring tab. Rinse the inner cannula with sterile water. In hospital, we use sterile long swab stick to clean the inner cannula. The brush supplied in the trachea kit is to be issued to patient upon discharge. After cleaning, place a washed inner cannula in a clean denture cup to dry. When putting the inner cannula back, make sure it's completely dry. For stubborn secretions, soaking with sodium bicarbonate can help. After which, please use sterile water to rinse again before leaving it to dry. For cuff trachea, cuff pressure should be maintained between 20 to 25 cm water. It should be checked using a pressure gauge manometer every shift or when suspected air leak. To detect air leak from mechanical ventilated patients, listen for leaking sounds around tracheostomy. For non-ventilated patients should not be able to vocalize when cuff is properly inflated. Please report persistent air leak to physician. Do not overinflate the cuff, as it may lead to tracheal damage or esophageal impingement. Do take note, for deflating cuff, to use a 10 cc syringe to aspirate all the air from the cuff. Using a pressure gauge may not be able to deflate the cuff completely. Clean the stoma with sterile saline at least daily or whenever the dressing gets wet or dirty to prevent skin irritation. During dressing change, to inspect stoma site for bleeding, redness, swelling, and discharge. To keep skin dry and provide comfort, non-fill gauze or foam dressing are commonly used to place under the trachea flange. We do not recommend to cut gauze, as a loose thread may enter the airway. We emphasize to have 2 persons when changing trachea tie. This is to prevent accidental dislodgement of the trachea tube, especially when the stoma is new. 1 person stabilizes the tracheostomy tube with another change the tape. Tracheostomy tube can be secured using either the cotton tie or commercial trachea tapes. The securement should be secure but not tight. A 1-finger spacing underneath the tie is recommended. If a cotton tie is used, take note not to tie the knot at the back of the neck to avoid pressure. For assessment and monitoring of patients with tracheostomy, the respiratory status, secretions, and incision appearance of tracheostomy should be monitored and documented, with any significant changes reported promptly. Tracheostomy complications can happen at different stages. For peri-procedure, we look out for bleeding, tube dislodgement, and procedure-associated complications. From day 1 to day 7, to look out for signs of infection, tube dislodgement, obstruction, and hemorrhage. Tracheostenosis, tracheomalacia, and tracheoesophageal fistula are the late complications happen after day 7. To be able to respond to tracheostomy emergencies fast, the suction apparatus, bed valve mask, oxygen, and tracheostomy emergency kit should be readily available at the patient's bedside. The emergency kit consists of scissors, 10 cc syringe, 1-inch surgical tape, gauze, lubricating gel, tracheodilator, and 2 cuffed tracheostomy tubes, which is of the same size and 1 size smaller. Take note here, the cuff tubes are used for the emergency backup, as uncuffed tubes are incompatible with mechanical ventilation. Please do not discard these items, especially during the trachea tube change. Make sure to remove the speech valve from the old trachea tube before disposing. Family and patient education for tracheostomy care involves teaching both the patient and their caregivers about tracheostomy care and managing potential complications. This education is crucial for preventing complications and promote overall well-being. Providing an alternative communication tool is important to reduce patients' anxiety. A common tools used are writing or pictorial material and digital devices like iPads, phones, or computers. When patients are in a general ward or at home, some simple precautions help them maintain a normal daily activities while protecting their tracheostomy and ensure safety during personal care routines. During showering, advise them to stand with their back facing the water and use a shower shield to prevent water from entering the tracheostomy. For men, the tracheostomy tube should be covered while shaving. Those are the supplies and consumables are available at the speech therapy department in the hospital. MDI can be delivered via an inhaler spacer for patients with no or little supplementary oxygen. Before administration, to change a non-fenestrated inner cannula if applicable. Now I'll be handing the time over to speech therapist, Ms. Grace.
Thank you, Sister Guo Ping. Now I'll be sharing about how speech therapists manage the swallowing and speech aspect of our trach patients. The left diagram is an example of normal swallowing. Food and water enter the oral cavity and is broken down into smaller pieces. When the patient swallows, the epiglottis closes to protect the airway, and the bolus gets squeezed past the pharynx into the esophagus. The diagram on the right is an example of a patient with a swallowing difficulty, also known as dysphagia. You can see the food or fluid particles entering the airway, which might lead to a lung infection. Swallowing in tract patients can be more complex due to changes in airflow, sensation, and secretions handling. As such, there are three key areas we need to monitor closely: breath support, secretions management, and risk of aspiration. For tract patients, we typically only consider starting diet and fluids when the patient's cuff is deflated. Inflating the cuff can mask signs of aspiration, impede normal swallowing mechanics, whereas a deflated cuff allows for assessment of laryngeal elevation, cough, and vocal quality, which are important indicators of swallowing safety. The modified Evans blue dye test is often used to assess a tract patient's swallow function. This involves feeding the patient's oral troughs of food or fluids dyed blue. After swallowing, the patient is tasked to cough with the inner cannula inspected and will require suctioning to check for traces of blue from the tract. If blue dye is noted from the tract site, the patient is deemed to have failed the test and aspirated on the oral troughs given in session. This aspiration may not be captured immediately and will typically require further monitoring by the patient and staff nurse in charge for the next 24 hours after the session. Because the blue dye test carries a significant risk of false negatives, we typically recommend for an objective assessment to accurately evaluate aspiration risk and guide our recommendations. This is especially so for newly created tract cases. There are two types of objective assessments that can be used to assess what food or fluids is safe for patients to take. On the left is a VFSS, also known as a swallowing X-ray. In this assessment, the patient is asked to eat and drink food or fluids mixed with barium so that we can track their swallows in real time. In this example, you can see that how the fluid enters the airway when swallowing, which triggers a cough response. On the right is a fees. A small flexible scope is passed through the nose to directly view the vocal folds and the surrounding structures. So fees allows us to assess for aspiration and also monitor how well the patient is managing their own secretions. In these two pictures below, you can see that there is pooling of saliva in the areas around the vocal folds. We typically manage swallowing issues by recommending food and fluid modifications. We also teach safe feeding strategies such as eating and drinking slowly or reducing distractions during meal times. Sometimes patients are taught compensatory strategies to increase swallow safety and swallow rehabilitation exercises to strengthen their swallowing muscles. As speech therapists, we also play a crucial role in facilitating communication in our tract patients. In normal voicing, air flows up the airway, passing through the vocal cords and into the mouth. To achieve effective functional speech in tracheostomy patients, maximizing airflow through the vocal folds is essential. The optimal configuration includes ensuring that the airway is open and unobstructed, a deflated cuff or a cuffless tube, a fenestrated tube, a smaller tracheostomy tube. This configuration helps to reduce resistance upwards and enhances airflow, which can significantly improve speech quality in tract patients. For patients who can tolerate cuff deflation, we have two effective methods to facilitate speech. When using digital occlusion, patients will be asked to use their finger to seal the end of the tube while speaking. This technique diverts airflow through the vocal cords instead of allowing it to exit through the tube. After they have finished speaking, they are asked to remove their finger to resume normal breathing. It is important to ensure that their hands are clean when occluding the tract site to prevent further bacteria from entering the airway. The second method is the speaking valve. This is a hands-free one-way valve that allows air to enter through the stoma and directs it upwards through the vocal cords during exhalation. We encourage the use of a speaking valve when tolerated, as it typically produces louder and clearer speech compared to finger occlusion. It is important to note that finger occlusion may not always provide a proper seal, which can affect voice quality. However, not all patients can tolerate a speaking valve. In SKH, we use the Portex speaking valve that is seen on the top right of this slide. The use of a speaking valve helps to improve voice function, increases sense of smell and taste due to more airflow being directed upwards. It also enhances the sensation of airflow, which may stimulate the cough reflex, which helps with secretions management. It also helps to provide a closed system to allow for better subglottic pressures during swallowing, and it expedites the weaning and decannulation process, which results in a shorter length of stay. For patients who are unable to tolerate cuff deflation or are unlikely to deflate their cuff anytime soon, we can consider two options. For patients on ventilator who can tolerate partial cuff deflation, we can work with our respiratory therapist colleagues to see if patients can voice with a leak. Another option to consider is above cuff vocalization, where we introduce air from an oxygen source into the subglottic suction port to allow air to go past the vocal folds. Their ability to voice is dependent on their body function, secretions management abilities, and vocal fold function. As mentioned earlier by Sister Guo Ping, these are other tools that we can use to aid in communication with our trach patients. Now we'll be moving on to talk about the weaning process. During the weaning process, when patients are suitable for cuff deflation, we'll start to consider downsizing of the tube. After which, we assess the patient's ability to tolerate speaking valve and progress them towards capping or spaghetting trials. Now, I'll be sharing some considerations for cuff deflation. Cuff deflation is an important step in the weaning process because it helps to facilitate the patient's ability to manage their own secretions and for swallowing. A paper by Pryor and his team identified that these three clinical indicators in red are sensitive and specific in determining if a patient is suitable for cuff deflation. Patients should be stable or show improvement in medical and respiratory status and have less than 1 ml per hour of above cuff secretions. This also indicates the importance of the presence of a subglottic suction port and the need for regular charting of above cuff secretions. On the right of the slide, these are some reasons why patients may fail cuff deflation trials. It is important to address these contributing factors before resuming cuff deflation. As we all know, patients who have been tracheostomized because of prolonged ventilatory support and airway protection cases are at higher risk of respiratory compromise and secretions management issues. As such, our respiratory and neuro caseloads often require more gradual and cautious cuff deflation trials, unlike our upper airway obstructions caseload. Now, I'll be handing the time over to Shuhada, who will be continuing to share the next stages of the weaning and decannulation process.
Thank you, Grace. Now I'll be covering about the downsizing of the tracheostomy tubes. Some reasons to how downsizing is a step towards weaning is because it reduces the upper airway resistance with a smaller tube in situ and therefore reduces any forms of airway trauma and irritation. This stage also facilitates speech and communication. Downsizing of the tube is usually considered once the patient successfully tolerates the cuff deflation trials. Some important factors that we consider and monitor before progressing to this stage would be similar to the cuff deflation stage. Important factors such as secretion and respiratory stability is pertinent. This is the summary chart of the common tracheostomy tubes available here in Sengkang Hospital. During the weaning process, we can downsize and even change the tracheostomy tubes type. changing to a smaller tube, cuffless tube, and/or fenestrated tube. This depends on the main objectives and purpose of change. For example, to facilitate speech like above-cuff vocalization or to reduce airway resistance for weaning. Some key things for us to note here would be that the inner diameter size are used to guide us for our suctioning catheter sizes. And for the outer diameters, they vary between the different brands too. Now I'll be covering how we can facilitate the weaning process. The physios work closely with the team to facilitate weaning. PTs assist with the airway clearance technique, functional rehab, and inspiratory and expiratory muscle training portion. This slide covers the common airway clearance technique that we do for our tracheostomy patients on top of the regular oral and tracheostomy suctioning. We do techniques like manual hyperinflation, cough assist, and also suggesting to the team on some of the possible pharmacological management that can be used to facilitate secretion clearance. It is important for us to note the amount, frequency, consistency, and color of the secretions too. These slides cover the pharmacological management of secretions. Here is a summary of the different mechanism of action of the different medication that we can suggest to provide to the patient. For example, suggesting for mucolytic versus mucoregulators depending on the secretion features like its consistency and amount. These are just some of the common medications that are used for the patients on tracheostomy with secretion issues. On top of airway clearance, we also cover functional rehab, which aims to improve their strength, endurance, and mobility. The exercises are usually curated and tailored to the patient's needs and problems. Lastly, we also do inspiratory and expiratory muscle training, which aims to target the respiratory and breathing muscles slightly more. For inspiratory muscle training, we aim to improve the inhalation phase, which helps with improving breathing capacity and reduces the issues of shortness of breath and reduced effort tolerance. While for expiratory muscle retraining, it aims to improve force generation, which in turn facilitates both airway clearance and the generation of speech. These are just the common tools or training types that we use to strengthen the patient's respiratory muscles on top of our conventional functional retraining. Now I'll be covering the final steps towards weaning, which is also known as decannulation. Decannulation is the removal of the tracheostomy tube. As you can see from the previous slides we have all covered, it takes the whole multidisciplinary team's input and consideration before proceeding with decannulation. It is only considered once the main indication for tracheostomy creation has been resolved. Other factors or medical criteria that we look at to determine the suitability of decannulations is as per listed in the next two slides. Neurological status of minimal GCS of 8 or more and the ability to have good and patent cough and gag reflex is important for the patient to protect their airways. Respiratory stability of nil recent acute desaturation and the patient's ability to protect their airway and cough is important. Swallow and aspiration risks are also ruled out through VFSS or FEES assessment. Do note that a failed swallowing evaluation does not contraindicate decannulation. Patient may just continue to be on NGT, jejunal tube, or even PEG feed. And lastly, patients should not be actively having an infection or have an upcoming surgical or oncological management that would require the tracheostomy tube in situ to facilitate its management. A step before ensuring that the tube can be safely removed, patients must be able to tolerate the spigoting trials. Spigoting is an act of placing a cap over the tracheostomy tube. It prevents both the entry and exit of airflow via the tracheostomy site, and patient will have to solely rely on their upper airways for respiration. The patients must be good at managing their own ventilation and pulmonary hygiene to pass the spigoting trials. Usually, based on the population type, a gradual versus faster decannulation process can be considered. In general, for the respi cases, a more stepwise and gradual weaning process is considered, while those patients that have a tracheostomy mainly in view of the upper airway obstruction, a faster weaning process can be considered. In SKH, the stepwise approach for decannulation is done. Usually, spigoting trial is started early in the week and targeted to aim for decannulation on the Thursday or Friday of that week. Spigoting trials are usually started at 15 minutes tolerance first and progressively increased over the same day and the next couple of days. By day 3 of spigoting trials, the patient will be aimed at spigoting for 24 hours straight. While the patients are ongoing this trial, our ST colleagues will be assisting with providing the spigot trial chart as seen in this slide. This is so as to ensure that the trachea and primary team assisting with the patient's care are kept in the loop for this ongoing protocol. Once a patient successfully tolerates the spigoting trial, they can then be decannulated. It is also important to monitor post-decannulation. Monitoring of the extracheal site is necessary and ensuring the area is kept dry and clean at all times. Regular dressing change is encouraged to prevent any reinfections, and monitoring of the stoma in the following 3 weeks is necessary. If the stoma is poorly closed, sometimes further interventions would be required. Now I will hand over the time back to Dr. Ganesh to cover on tracheostomy emergencies.
Hi there, I'm back. Okay, so we are coming to the last but not the least. Okay, so here we will cover a few trachea emergencies. For example, let's see what we would do if we have accidental decannulation, if there is a tube occlusion or a tube dislodgement or a hemorrhage. Okay, so when you're approaching a patient who has an emergency, so you're going to see the patient. So you should have these key questions in your mind. Are we going to deal with a tracheostomy patient or a laryngectomy patient? We already covered this in the introduction, right? So if you have a laryngectomy patient, you cannot oxygenate them over the face, right? So they don't have a connection between nose and mouth and the trachea. So that's number one. Number two, why was the tracheostomy placed to begin with? So if it's placed for a low GCS, for example, if the patient is awake and alert, you may not need the tracheostomy to be placed in so fast. Okay, so you need to know why was it placed, how long has it been placed, how fresh is the tracheostomy tube. Be it less than 7 days from the day of placement, the tract is not matured, so you may have to consider ventilating them through endotracheal tube, for example, rather than putting the tube in. So you need to know whether they have any previous complications, how much oxygen requirement the patient has, and how often they need suction and so forth. In terms of essential equipment, it's been covered by my colleague before, but so just to say that there is a suction nearby, ambu bag, and trachea tubes plus minus one size. A size 6 ETT would be more handy if you have an issue with the trachea tube size match. You can always put in a size 6 ETT in the stoma. Okay, so a bougie and so forth. Monitoring equipments will be helpful. Okay, so first of all, let's go with accidental decannulation. This happens because patient moves suddenly, or you are trying to move the patient from a stretcher to the CT scan machine, for example. The most important is do not panic. If we panic, we do more harm than good by, for example, picking up the tube and rushing to put it back in. There is a chance that you convert one emergency to another emergency, say tube dislodgement. Don't look at the tube, look at the patient. The hole is not going to close at all in the next 30 minutes. The hole will be there open. So the patient may be comfortable, so you don't need to rush. If the patient is breathless, organize your thoughts, call for help, put on oxygen on the face and also on the stoma. And if the tract is matured, like I said before, more than 7 days, you can always replace with a new tracheostomy in. If the tract is not matured, then you get a help, whether to intubate from above or the ENT colleagues can dilate the tract and then use the same to put a trachea in themselves. Okay, let's say the patient has a tube occlusion. How do you know? So this is, they present with sudden respiratory distress. It could be tube related, or it could be the airway spasm or pulmonary edema or pneumothorax. So, but first thing is to take the tube out of the equation. So think about tube occlusion here. It's more common. It causes of almost 30% of the respiratory distress. So what you need to do is you can use this mnemonic. So remove, oxygenate, reestablish. That means you are going to remove. So first of all, remove all the accessories in the tube, be it a cap or a speaking valve, for example. Remove those things. Remove the inner cannula. Inner cannula, then you just put a new cannula in. If you solve the issue, fine. If you're not solving the issue, you can deflate the cuff. So deflate the cuff also hasn't solved the issue. You can do a suctioning, see whether it works. If it doesn't, remove the tube itself. Oxygenation, you can oxygenate them in the face and also in the trachea, the stoma side. Okay, so when it comes to reestablish, you think about again the same thing. Tract maturity is the main. So if it's not matured, go for intubation from above. So the next emergency will be a tube dislodgement. These patients may present in a subtle way, as the tube may have a connection with the airway still, but they may be all misplaced in a different fascia, for example. So you can see patients presenting with breathlessness and also subcutaneous emphysema, like you see in the picture. The outcome can be disastrous. So you need to think about this emergency when you're dealing with the trachea patient. So you may feel that they are having the trachea tube is not blocked, but it can be misplaced. So high-risk patients are those who are obese and who had a recent trachea change. Again, remember this: remove, oxygenate, reestablish. So you remove the tube. This time the tube is not functioning, so remove it, oxygenate the patient from above and also in the stoma, and then reestablish. By reestablishment, be careful. This is a dislodged tube, so you may need help. So get an ENT colleague or somebody who knows what they're doing. Right. So for the last scenario, hemorrhage, I will go back to my same old patient. Let's say my patient who had trachea, I discharge him home and he's coming back. Now this time he comes with hemoptysis and cough. He comes to ED, so his temperature is slightly elevated. His vitals are stable. He's saturating 100% on room air. You go and examine the trachea. There is no obvious bleeding visibly. He appears well. So it's easy to take these kind of patients lightly. You can start antibiotic thinking it could be a lower respiratory tract infection and send them home with the ENT consult in 1-2 days. But remember, this could be a sentinel bleed. That means any bleeding or hemoptysis in a trachea patient, if it's more than 10 mils, it goes directly to OT for exploration due to this deadly complication called tracheoinnominate artery fistula, TIF. We will discuss about this in a little bit. Okay, so for any patients with bleeding, take it seriously. Okay, so if it is within 48 hours, it could be procedure related. So we can check the coax, get the procedures to help you. If it's more than 48 hours, it can be due to suctioning causing damage, or it could be granulation tissues. So you ask these questions, whether this bleeding is coming from inside or around, or whether this is an arterial bleed or a venous bleed. If it's around, just lift the face plate and look around, see if you can apply some pressure bandage, check the coax profile of the patient. And if, let's say, if it's inside and it's venous, it's not that much, you can always cough up the tube so that the bleeding is not entering the lungs, and you can do the suctioning, see whether it helps. If you need more information, you can arrange for a CT angiography. Right? If, let's say, it's from inside the tube and it's arterial, there it's an emergency. So you should get ENT stat. Okay, so don't waste time over here. So this is the deadly complication we are talking about, tracheoinnominate artery fistula. This innominate artery is the first branch of the aortic arch, and it becomes the right subclavian and the common carotid artery after that. The occurrence of this fistula is very rare. It's about 0.7%. It usually occurs in the first 4 weeks, but the mortality is very, very high, 97%. So while we are waiting for the ENT to come in, what we can do to resuscitate them. So hyperinflate the cuff. Don't worry about cuff pressure. Just go high on the cuff. You can see on the picture, the cuff exactly sits at the spot where the innominate artery is. So cuff it up. If you are not succeeding, you can put in a ET tube and then cuff below so that you can protect the lungs from the hemorrhage. The other thing you can do is while you are ventilating the patient from above, you can put your small finger into the stoma and then just do this Utley maneuver, which can help stop the bleed while you are getting your help. Okay, that's all I have here. I open the floor for Q&A. Yeah. Uh-oh.
I think we will take all questions now. Some of the questions have been answered in the Q&A dialogue, but there have been few questions that have been placed here. We will answer. So I think the popular question seems to be, get 3, 2, 1 Ws. What exactly does that mean?
Okay, so I'll come back to you on that in a minute. So let me answer the other question here. So this size of the tracheostomy tubes, right? So okay, usually for sizing we go for the largest size when we initiate the tracheostomy, so that it will facilitate proper ventilation. So usual, for example, Portex 7.5 adult size is the one we prefer. Eventually, when the patient is off ventilator and is ready in the weaning stage already, we can downsize the tube, as it's already been mentioned. So regarding sizing, we always look at the outer diameter of the tube. For example, if you want to put a Shiley 6 and you want to change from Portex 7 to Shiley 6, what we need to know is what is the outer diameter of Portex 7, and then see whether it is within the frame of outer diameter of Shiley 6. Okay, so the outer diameter should fit in with our new tube. Shouldn't be the more than the previous tube. Okay, so in terms of, there's a question, how long do we consider a trach as a new and fresh and that may still be unstable? Okay, so we usually use this 7 days cutoff for the tracheostomy. But this applies more for a percutaneous tracheostomy because the surgical one, the tract would be formed much earlier. So by day 4, a surgical tracheostomy should be considered mature. But we normally don't know when we are dealing with emergencies, right? It's very difficult to find out whether it's a surgical one or a percutaneous one. So it's always be on a safer side to keep 7 as the cutoff.
Someone requested for the weaning tracking slides. So I'll just show it for you guys. Is it this one? We're just replying some of the questions live on the question and answer poll. So if you have any other questions, feel free to send through.
The supposed benefits of trachea that have been debunked. Oh, yeah. Okay. So so there is a question I'd like to ask: if patient trachea dislodged at home, do we just ask them to come ED, and if have oxygen to put on first? Yes, I think the answer is yes. May they may have to call ambulance. Depending on how bad is the patient, like this in respiratory distress, they may need an ambulance support. Yeah. So the other question is, sometimes when patient cough too hard, trachea drop out, we immediately put it back. Is there any things we need to take note? Okay, yes, I think I covered this in my emergency thing. Don't try and rush and put it back on. So there is always a chance that we create a false track. So also make sure we settle the patient first and then get a proper tracheostomy tube. And the tube which fell down may not be an appropriate one to go back in. Okay, then you initially resuscitate the patient, put them on oxygen, make sure they are okay before you go back and wait. Okay, so this during tracheostomy care, if you encounter subcutaneous emphysema around the insertion site, what should be the immediate action? Okay, so if there is usually after the immediately after insertion, you can see there is some subcutaneous emphysema. So maybe we need to loosen, if there is a suture in the tracheostomy, we need to loosen the suture. If it is happening a long time after the tracheostomy insertion, then we may need to think about this dislodgement, which can cause emphysema, subcutaneous emphysema as well. So answer the question for the 3-2-1. Okay, so 3-2-1 is a rule used by the UK National Tracheostomy Safety Project. So the 3 is actually try to pass a suction catheter whenever there is a block in the trachea tube. 2 is, if the catheter doesn't pass, try to deflate the cuff. If still no ventilation, number 1 is remove the tracheostomy tube. So they use this number to remember this, the logical steps.
I think there are a lot of interesting questions that are coming in the Q&A. We are trying to answer the questions as much as possible. We may not be able to answer all the questions, okay, but we will still take last few questions if anyone has.
So in an emergency, there's a question. So in an emergency or in A&E for desaturation, where the humidification, etc., etc., is not set up yet. Do we put NRM over both trachea and mouth? It depends what is the emergency. So if the tube is blocked, for example, putting an NRM over the trachea may not work. So you may need to deflate the cuff. If it's still blocked, you may have to remove the cuff and then put the oxygen through the stoma and also in the mouth. Oh, so asking for W. W is a work through stoma. So it's actually this 3-2-1. It's like I said, first is a suction catheter, second is deflate the cuff, third one is to remove the tube, and W is a work through stoma, so work of suctioning. So this is the protocol. How do we provide? Do you teach patients to remove and replace tracheal tube on their own? For patients who have been having the tracheostomy for a long time and trach has been very well formed. Oh, so regarding the question, do you teach patients to remove and replace the tracheal tube on their own?
Yeah, they
For
will
who
come every
have
3 months.
usually we don't advise the patients to do the change. So depending on the tube, if they are having a tube which can last for 3 months, we will ask them to come back at the end of 3 months to change. Yeah, it's not advisable for the patients to change the trachea tube.
Okay, I think this has been a very comprehensive session, and I would like to thank Dr. Ganesh Ms. Goping, Ms. Luzel, Ms. Shuhada, Ms. Grace for this very comprehensive and detailed session. And I'd like to thank everyone for taking time out from their lunch and kind of attending to the session. And the very fact that we had so many question and answers, it means that we've been kind of, had a very good session. Some questions which have not been answered, we will still try to answer as much as possible. But if anyone would like to contact us, can contact our team for the Trach service. We will try to collaborate, okay? And I think this webinar really proves that Trachea Care is an interprofessional collaboration where each member of the team has very valuable inputs to be given, okay? And if you have any feedback for this session, please scan the QR code. And from Sengkang ICU, we would like to thank you for your patience and for your very interesting questions that we had. Thank you.
Thanks very much, SKH team. This has been very, very informative.
Thank you.
Thank you everyone for attending the webinar today. We'll be ending the webinar here. Take care. Oh, and do fill out the feedback if you are able to. Thank you.